these are the topics we're going to cover quickly, just the definitions, what are the major causes of death, and then some causes of AKI and their general approaches in the ICU. So acute kidney injury is very important, and the AKI EPI study, which was in 2015, showed that of patients in ICU, at 7 days, there's a 57% incidence of stage 1 and 39% incidence of stage 2 or 3, and 13.5% of these people actually need renal replacement therapy at 7 days in the ICU. So it's really like a prominent concern that we have for patients who are admitted in ICUs. These are the definitions of acute kidney injury, basically, and there's kind of two groups that have, there's three actually, but these are the two major ones that we use to define acute kidney injury. And a whole lot of what we do in internal, at least, is like documenting input and output and monitoring the urine output for these reasons. So stage 1 acute kidney injury, according to the KDIGO, is an increase in the baseline creatinine of 26.5 micromoles per liter, or an increase in 1.5 to 1.9 times the baseline, which happens fairly frequently, or urine output, which is less than 0.5 moles per kg per hour for 6 to 12 hours. If that's increased to 2 to 2.9 times the baseline, or less than 0.5 moles per hour for 12 to 24 hours, that's a stage 2. And then stage 3 is an increase of 3 times the baseline, or if the patient requires renal replacement therapy, or if the eGFR is less than 35. And I was very surprised by how high that number is, like that's not a very low number. And I think separating chronic kidney disease from AKI is important. And we'll go over kind of the concept of measuring GFR and stuff as well. The rifle, basically RIF, is fairly similar to stage 1, 2, and 3 in the KDIGO, except that the urine output is 0.3 moles per kg per hour for 24 hours, or anuria for less than 12 hours, meaning that anuria is then less than 100 moles per 24 hours of urine production. And then it goes, so risk, injury, failure, loss, and then end-stage kidney disease. These patients are the patients that end up on renal replacement therapy for longer than 3 months. The causes of death in AKI, I mean, we always think about the usual suspects, which are electrolyte abnormalities, the hyperkalemia predominantly, uremia, volume overload. But each of those things can be managed with dialysis. And yet mortality in these patients remains high. So it's not each individual little thing like that really is the major killer, but the fact that this all occurs within a patient in that specific context with multiple small mechanisms that are yet poorly understood, but we'll try and get into a few of them. And you can see how AKI affects every organ system through the microbiology, through the pathophysiology, and all these little markers of inflammation that are released in these patients. So it's really just a system-wide approach to managing these patients with acute kidney injury. I thought this was interesting, not something necessarily for us, but just that there are some clinical risk prediction score systems that you can use to see, will this patient develop AKI? And someone's actually published a study in 2019 where they looked at the random forest model, which is some computer algorithms that can be used to detect AKI. I haven't gone into any detail to figure out how they work, but apparently they can detect AKI up to 6 hours earlier than lab markers, which I thought was extremely interesting. And then sometimes, although we don't necessarily think about it in the ICU, we do often give these patients furosemide, maybe not intending for it to be a furosemide stress test, but it's just let's give and see sometimes. And if you think about it in this context, we can actually make a fairly confident diagnosis if we got concern as well. So just a very interesting little table to look at. So going on to some causes of AKI in the ICU, these are like an in detail look at some of the causes of acute kidney injury. I haven't gone into detail into managing like each specific glomerular disease or each specific cause of ATN or whatever. But I just know that they're wide, varied. The kidneys are extremely important in managing so many different things. And we're going to go through an approach to how to think about these causes of AKI. And the way I like to do it is like this. So pre-renal, intrinsic kidney, and post-renal causes. Pre-renal causes, according to some of the notes that are usually the most common in our patients, and this is usually associated with hypovolemia or hypotension, decreased cardiac output, vasodilation, renal vasoconstriction, and impaired renal regulation. And we often see these patients who are, losing fluids from some reason, whether it's bleeding, GI losses, burns. These are the patients that will get free renal. And if you have any difficulty kind of diagnosing this, you can look at a few parameters. The urine fractional excretion of sodium, which is the urine sodium of the patient divided by the plasma sodium. Get that answer, divide that by the urine creat divided by the plasma creat, and multiply by 100. So as a percentage, basically. And if that's less than 1%, it's more likely to be a pre-renal cause. You can also look at the urine creatinine ratio. If it's more than 70, again, it's basically using the same parameters to try and decide this. And then concentrated urine with Highland casts, most likely to be pre-renal. Whereas intrinsic causes are most likely to have a urine fractional excretion of sodium that is more than 1%, a urine creatinine ratio that is between 40 and 60, a spot sodium that is higher, dilute urine, and granular casts. And then to look at the intrinsic causes as parts of the kidney. So vascular causes, glomerular causes, of which there are many, and tubular interstitial causes. So vascular, we often see patients with vasculitis, and the big ones that you think of is ANCA. You think about connective tissue diseases like SLE, scleroderma renal crisis. You think about microangiopathic hemolytic anemias, and then also thrombosis of the vascular system, whether that be venous or arterial in that system. Glomerular causes on the spectrum of nephrotic causes, and then tubular interstitial. So acute tubular necrosis, which is the most common cause of these, can be related to ischemia from some hypoperfusion, nephrotoxins, which include ACE inhibitors, non-steroidals, some chemotherapeutic agents, and then rhabdomyolysis as well. And then acute interstitial nephritis, which may also be related to some drugs, and then crystal gout nephropathy, cast nephropathy rather, tuberculosis syndrome, multiple myeloma, acycliva precipitates as a crystal as well. So that's to think about these causes. Post-renal cause, the most, at any point along the urinary tract, whether that be, upper or lower, obstruction can cause effectively a acute kidney injury. And we see that quite often, I think, in these patients that come to EC with their big prostates and in acute renal or acute urinary retention. Something I think I've felt is that there's maybe just the concept of when to call, say the patient that has got urinary obstruction versus obstructive uropathy. And I just want to maybe bring this here that in my mind, obstructive uropathy implies almost a kidney, that it's affecting the kidneys, whereas urinary obstruction doesn't necessarily do that. So just something to think about. Talking a little bit about the pathophysiology of AKI then, it's just reading about it, it's getting super, super complex, and a lot of people are doing a lot of work on trying to identify specific markers and proteins and inflammatory cascades, but effectively it all interlinks. So nephrotoxins, ischemia can cause some tubular damage. Inflammatory causes also cause interstitial inflammation and vasoconstriction with the release of some peptides and activating the renin-angiotensin aldosterone system. which can potentiate other effects. You also get obstruction of the tubules then by these dead cells. So if you've got tubular cells that are dying because they've been affected directly by a toxin, or they haven't received blood, then those dead cells can slough off into the tubes and block them, and you can get a tubular back leak with increased tubular pressures as well. Then those increased tubular pressures would effectively decrease your GFR and your tubular flow, resulting in oliguria. Obstruction also works backwards into that process, and if you think about rhabdomyolysis, direct tubular damage as well as blocking the glomeruli. So it's a complex process, and that's without any of the detail that some proper scientists are working on at the moment. It's very impressive to read. So going through the major causes, and this one is the big one. In our ICU and in ICUs all over the world, sepsis is the most important cause, the most common cause of AKI in the ICU, and it causes about 50% of these cases. AKI will occur in 50 to 70% of patients with septic shock, which is a big number. So defining sepsis according to the Sepsis 3 guidelines is effectively a life-threatening organ dysfunction caused by a dysregulated host response to infection. I think that dysregulated host response is the important part of that understanding, and something that we've gained over the last few decades. AKI is also an independent risk factor for sepsis. So for the surgeons, if you guys take a patient to theatre who's not septic, but they've got an AKI, the one study showed that 23.7% of post-op patients with AKI got sepsis at day 5 on average, versus 3.3% of patients who didn't have an AKI. So I thought that was really interesting and speaks to adequate resuscitation pre-op, and the use of appropriate sized IV lines, and making sure we're being targeted in our fluid management. 56% of patients with an AKI not related to sepsis developed sepsis at 5 days. So it's just like 2 ways of proving that AKI and sepsis are interlinked. We used to think, or the prevailing theory was that sepsis was related to global hypoperfusion. This person may be in shock, a distributive shock, but new evidence is showing that actually it's probably not just due to the global hypoperfusion. And some animal studies are showing that renal blood flow may actually increase in sepsis. And if you do post-mortems of these patients, there's usually no evidence of acute tubular necrosis. So this leads us to think that this process is probably multifactorial. And thinking about the microvascular dysfunction with endothelial dysfunction that is precipitated by this inflammatory cascade that is brought about, oxidative stress, inflammatory response to the sepsis itself. So it's not as simple as we think it is. And I think this is why this article in general actually has structured its approach to each cause for an AKI in this very clear syndromic way that we can actually manage. It's not speaking about specific small level causes, but rather gross causes that we can see in our patients, sepsis, shock, those sort of things, because this is a concept that all interlinks to itself. So management, I'm not going to go through the surviving sepsis guidelines in detail here, but appropriate antibiotics and fluid resuscitation, as we've discussed at this topic before. One study, according to this article, showed that there was some benefit in early renal replacement therapy, but that's not been kind of shown in other studies. So it's a bit unclear at this stage. And I think in our setting, we really need to decide and choose our candidates well for renal replacement therapy, given how much resource restriction we have.
I think the 2 studies, the Kiki and the Elaine, I think the most recent.
Yeah, I read about the Kiki.
Yeah, they showed that there's no mortality benefit, but that earlier, or if you wait, there's some patients that didn't need renal replacement therapy.
Yeah.
So I think for a third world setting, that's probably appropriate for us.
Yeah.
To not just dialyze early, but actually just give it some time for something like that.
Yeah, jumping the gun maybe.
Mm.
Yeah. Okay. A secondary major cause of AKI in the ICU setting is shock. defined as circulatory failure resulting in inadequate cellular oxygenation with evidence of tissue hyperperfusion. And in my mind, this is a little bit of a circular argument here because we're saying oliguria is, a sign of shock, but shock is now we're talking about it in the context of a cause of acute kidney injury. And it's not really circular. It's just that we're speaking about the same concept from two different directions. So oliguria is evidence of poor perfusion of the kidneys. Altered mental status may be evidence of poor perfusion of the brain. Full clammy peripheries and an elevated serum lactate, the gold standard of assessing hyperperfusion in these patients, and proving that there's evidence of shifting towards an anaerobic metabolism. So the four big groups of shock, as we all know: hypovolemic, whether that be hemorrhagic or other fluid loss, distributive, obstructive, and cardiogenic. And there's a little table that I put in the corner here that just kind of shows you how to differentiate between each of these things and then some major causes thereof. I think we're all quite familiar with this, but it's important to think about. This was a cool diagram. I've never seen it presented like this before, and often we thought I had a good understanding of the differences between our inotropes, but that little graph on the right there really does show you on something that's visualizable what each effect of these drugs is. So on the y-axis, you got kind of a continuum from vasoconstriction to vasodilation, and on the x-axis, the inotropic effect. And you can see that, for example, high-dose dopamine or low-dose epinephrine and high-dose epinephrine have different levels of function for different axes. So another way to think about this would be alpha and beta activity. So just a very interesting graph to look at and to see why, for example, norepinephrine may be the preferred agent compared to epinephrine, just given that it's more a vasopressor than an inotrope, compared to what we usually use, which is epinephrine.
So that suggests that noradrenaline is more potent than adrenaline.
Well, more potent as a vasoconstrictor, but less potent as an inotrope. Yeah. So just an interesting thought process about seeing which of these drugs would do what and why. For example, dobutamine is actually going to cause vasodilatation, and why we use it then for cardiogenic shock, but not the other causes, Yeah, so just an interesting approach, and I thought that was really cool to see. Very interesting as well is the development of some novel biomarkers, which of course we're not going to necessarily be able to use in our setting, but just to know that these are in development, and a couple of these have already been evaluated and approved. So if you look at the product of the TIMP2 and the IGF-BP7, that value in the correct patient with the appropriate pretest probability can be useful in detecting an AKI in these patients. So just important, again, it's the same thing as, proBNP or troponin or whatever test we do, that you have to use it in the appropriate setting. And because if you take it away from that good pretest probability, you might not find it as specific or sensitive as it would be in the correct setting. But just interesting to know that I never thought about biomarkers for acute kidney injury before, and that these things may exist.
It doesn't involve urine dipstick as well.
Yeah.
Well, these things is a finger prick, a point of care one also.
Yeah. So all of these can be urine, and then two of them I think are serum. Yeah, on the left there. Yeah. So it's just interesting to see. I don't know what the utility is, and whether or not doing something like this would make more sense than a scoring system or just looking at the definition. But the fact that they exist is just interesting to know. Yeah.
Especially, they sometimes get used for early detection, so the biomarkers may start to go up prior to giving other features of renal dysfunction. So oliguria and perhaps an increase that may be detected already.
Yeah.
Might be useful in a subset of patients, where you wonder why, you don't get the adequate urine output, but is it or the kidneys are actually unhappy. So it might be useful there, because sometimes you get some patients, any stress is going to cause the kidneys to conserve fluid, so it might be, but I don't know if it's going to hit.
No, I don't think it's necessarily going to be for us, but yeah, it's just interesting. The third major topic is, or cause, is respiratory failure. And again, you'll see evidence of how everything in our bodies is interlinked. I like using this little fusion GIF here, because it's the article put it as basically AKI and ARDS together increases mortality 2 to 3-fold compared to each independently. So that, like, if you have it together, it's really, really not great for the patient. And each is an independent risk factor for the other. So they work positively against each other. There's a complex pathophysiology, again, involving inflammation and endothelial dysfunction, as well as downregulation of pulmonary sodium and water channels. And then also the damage that we cause as doctors with our mechanical ventilation. And we had a talk by Prof the other day that I was sad to have to leave. But yeah, just thinking about all of these together, how the complex pathophysiology fits together. To define acute respiratory distress syndrome is then if the patient has an onset of this problem less than a week, chest X-ray showing bilateral opacifications, pulmonary edema that is not better explained by cardiac failure or fluid overload, and then hypoxemia. And I think we're all quite well versed with this from COVID days with the PF ratio. Mild being less than 300, moderate less than 200, and severe less than 100 millimeters of mercury. And then going through ventilation, lung protective strategy is our management for these patients, and just understanding that allowing a permissive hypercapnia in these patients is what the studies did allow, to allow us to do this lung protective strategy, and it did show an improvement in mortality. Fluid balance is important in one of the trials that was mentioned, but as we discussed previously, it doesn't have its primary outcome is mortality, and it didn't show a mortality benefit, but conservative fluids really is the way that everybody seems to be going at the moment. And this study did show an impact on ventilator and ICU free days. Yeah, so that's kind of part where we're going. Liver disease, just thinking about acute liver failure. We're not going to talk about chronic liver disease here. So acute liver failure in patients who've effectively make the diagnosis by seeing hepatic encephalopathy of any grade, INR of more than 1.5 or equal to 1.5. Onset is less than 26 weeks, and there's no evidence of cirrhosis. And the major cause in the USA, from which this is paracetamol toxicity. I think that probably applies to us as well, although maybe the percentages might be different. I think we might see a bit more viral hepatitis and some ischemic causes as well. But yeah, those are the major causes by a long shot. Overlapping, the pathophysiology again overlaps. So all of these things together affect each other, and the complications of acute liver failure can be AKI, can be cerebral edema with progressive intracranial hypertension, coagulopathy, hypoglycemia, and multi-organ failure. So you can see how they interlink with each other. In terms of managing these patients, mannitol for the use, so mannitol itself can be used as almost like a furosemide stress test, to see if the kidneys are going to be able to produce urine as a diuretic. So, but the dose in that instance is then 200 milligrams rather than 1.5 to 2 grams per kg. So it's a completely different concept. Mannitol you would be using here for prevention or treatment of cerebral edema. So just understanding that is a different task when you've got a patient who's got an AKI as well. And then hypertonic saline is the other option, targeting a serum sodium of 145 to 155. And again, considering early renal replacement therapy as a means of managing that hyperammonemia.
So it's special for HEPA filter as well, that actually specifically reduce the bilirubin separately as well, so you can kind of sort of put it in series.
Mm.
So normal dialysis filter and HEPA filter, or you can just alternate.
Is it like during the renal replacement?
So during, or you can say use one filter if you just for clearing the micromolecules like urea and the middle molecules like beta-2 microglobulin. So, and then at another time dialyze patients with the HEPA filter that specifically removes the ingredient and the
Okay, so this is something that also was interesting for me, and it really grated me to think about ACS as abdominal compartment syndrome and not. So I was like, wow. Okay. So for the surgeons, but actually for medical patients as well. So intra-abdominal hypertension and ACS, and normal intra-abdominal pressure is effectively 5 to 7 millimeters of mercury. I know that you guys often pump the patients up to like what, 18,
15 in theatre.
yeah, with scopes. So sustained just by doing that, you can cause intra-abdominal hypertension. Obviously, that's an expected outcome. And then abdominal compartment syndrome is if there's sustained elevation more than 20 millimeters of mercury. And you can estimate this by using pressure transduction of a transurethral catheter. I haven't yet figured out in my brain how to do that.
We do it, but I think like I wouldn't say. I think in the past, what happened is because of aggressive fluid management, we had medical patients that actually developed into abdominal compartment syndrome. But I think it's probably with that fluid balance, and I think now that we're a little bit more conservative, I think it's unlikely that any of your patients are going to. I mean, medical patients develop intra-abdominal hypertension. We had this patient with a pancreatitis last week that we actually pressure transduced, but you know, once you felt that, you think like, I'm not weird, that feels tight, you know. So I think you're welcome to put a band on your medical patient, but the chance of that developing, I think, is highly unlikely, unless there's an intra-abdominal problem there.
Yeah.
it's more of a surgical.
Yeah.
Pancreatitis.
Pancreatitis is a classic one.
So the guidelines for abdominal compartment syndrome is abdominal compartment syndrome society.
There's congresses on ACS.
Yes, they are. Cardiology department.
How long is the patients that they actually advise that you do routine transducing of the only thing that is the guidelines, depending, just look what you, because some of them are millimeters mercury, others millimeters.
So I think most of them are actually water. So last week we did it, and then you got to convert it. Because we used the
form, so actually gas weight.
Because you use the normal arc line on the catheter.
Yes, yeah.
So then you get millimeters mercury. So you got to convert it to centimeters water.
Yeah. I mean, like in terms of the management, and I think our patients have always got nasogastric tubes if they need them, paracentesis of, fluid or ascites.
I guess the one is probably the liver failure patient that they might have a little bit increased intra-abdominal pressure with all the ascites that's maybe. Hopefully it won't end up in ICU.
Yeah.
We're not talking about absolute entities that stand alone, right? So you might have someone who's already hypertensive and on a little bit of iron curves, and their fluid management hasn't been great, and they've got a little bit of sepsis query on board and blah, blah, and now they've got, a little bit of increased abdominal pressure. So these things act in concert and not always standalone entities. So I think it's something that, I think that's probably where the scientists come from, to rather do a routine that you know where you stand, because it might not be an absolute value so significant than a lot of factors working together at lower levels.
Yeah. And like thinking about the physiology there is also interesting. Are you compressing? If you got a patient who's in the ward or in ICU and you do an ultrasound of the IVC, it's not going to mean as much in these patients because the IVC will be compressed because of the pressure. So just to think about these things in those patients. And then sedation with intermittent neuromuscular blockade was one of the options as well. I did hear anesthetists talking about a tap block just for this reason sometimes, which is an interesting thought. And then just the last little bit on this topic is just drug dosing in AKI. And because there's so many variables that affect drugs in so many different ways, and it really depends on what kind of drug and what the volume of distribution is and how protein bound they are, what the protein's actually doing in these patients, altered clearance of the drugs, whether it be the liver or the kidney, a whole lot of other factors, that this is a complex topic to try and assess. And basically what it comes down to is being vigilant, monitoring your GFR, and then adjusting doses as needed. Usually the first little bit of an acute kidney injury, you don't necessarily need to adjust doses, just because of these changes in volume of distribution, and hopefully it's early on that you might be able to, return your calculated GFR to normal. But yeah, just keep your finger on the pulse and make sure that we're checking and adjusting the doses of the drugs that could be problematic. And we can check each drug that we give. So there's a lot of resources, and UpToDate is what we use most often to actually look and see, okay, in this instance, what can we do for the dose of this drug? And AKI does often have slightly different requirements to chronic kidney disease, so just check these things with each drug that you think may be a problem. And the drugs we're thinking of here are most often, antibiotics, anti-epileptics, thinking about enoxaparin. These are the things that we are often giving to our patients, and can cause problems if we just forget to adjust, the marrow for 2 days, those sort of things. So yeah, that's just a thought about it. And this is the article that I mostly used, that was sent to me. It's a very, very nice read. It goes into a little bit more detail, and the critical care nephrology, those core curriculums, are just like, it's between 12 and 15 pages on like a topic in general, and yeah, interesting to read. So yeah, thank you.